There was a moment when she was able to sit with me and she was able to say, "Do you really think that my brain might have created that?" She was one of the first people I worked with that really developed like a real level of insight. It was a different experience for me to work with, but she was able to say that. And I said, I don't know, but yeah, I think it's possible. And maybe if taking medication made this experience different or change or go away, maybe that means that it was.
You're listening to Conscious Mind.
Hi, everyone. Welcome back to the show. I am welcomed here today by Dr. Laura Gardner, who is the director of the Psychotic Disorders Program here at Silver Hill Hospital. Dr. Gardner has been with us since October of 2025, so relatively new to our place here, but certainly not new to her field of expertise. So I know this is going to be a really interesting conversation today. As I have said in this show in the past, this conscious mind is not, what's your resume and what have you done? It's more of those deeper, thoughtful questions that we all think about as professionals in this field. And we want to hear from our experts on kind of what keeps them up at night and what do they think the future of the field looks like and some of those more kind of interesting conversations. So welcome.
Thank you. It's great to be here.
Why don't you just tell us a little bit about who you are and what brought you to Silver Hill and what drew you into the field that you specialize in, which is treating some pretty challenging disorders. We'll talk a little bit about psychosis in general and what the public perception is, the existing mystery still surrounding some of these conditions. But I want to hear from you. Why are you here? What brings you here?
So, history leading up to coming to Silver Hill. I am from Texas. I went to medical school in Texas, and then I came up to Montefiore Medical Center and Albert Einstein College of Medicine for my residency program. I did my residency there. I already knew that my interest, by the time I decided on psychiatry, I already knew my interest was in severe mental illness, typically, involving psychosis, schizophrenia, that lands people in the hospital, that often those people don't get the care that they need or that we would want them to get on a regular basis on the outside. And so, I knew hospital-based psychiatry was going to be my area of interest that I was going to specialize in. So I did my psychiatry residency there. I stayed after my residency on the primary teaching inpatient unit at Montefiore Hospital. So I was an attending psychiatrist there, and I also did ECT there, electroconvulsive therapy. I trained our psychiatry residents there, trained medical students at Albert Einstein College of Medicine in psychiatry, and stayed there. I was promoted to the director of the inpatient service there. I was there a total of almost maybe like 7.5, almost 8 years after my residency. Um, and then moved on. I went to Northern Westchester Hospital to work for a former mentor of mine who had actually been at Montefiore Hospital before that. And I was the associate director of behavioral health there under him. And so I got to do a bit of a mix of things there, consultation, emergency room, and inpatient work. So it was kind of a nice balance. I was there for 3 years and then came to Silver Hill to lead the Psychotic Disorders Program. And I think what sort of led me on this trajectory was really looking for a place where I can grow, where I can specialize more in exactly what I like to do, but also where I can provide the kind of treatment that I want to provide, that I can feel really good about, sort of ideal treatment for this population of patients that are experiencing long-term psychosis, psychotic disorders, whether that's schizophrenia, schizoaffective disorder, bipolar disorder. So treating those patients, doing that in a residential setting, at the lodge like we do here at Silver Hill is really ideal treatment. I have a lot of frustration, and I talk a lot about the limits of our healthcare system right now, particularly with inpatient psychiatric treatment, how so much of that is dictated by insurance companies and reimbursement and the business side of medical care. And with this particular population of patients, a week or two on an inpatient unit or even a couple weeks it's just not enough. That might be enough for
Definitely.
somebody struggling with a different kind of illness that needs just acute stabilization. Often it's not enough for people experiencing psychosis, and they really need more intensive and more comprehensive care. So I find that this is a great place where I can do that, and I can do that, for a longer period of time and really get people, you know, better where they can actually function back in their lives.
Thinking back to when you started, so I don't know if you started studying psychology in undergrad or, at what point in your life you took that journey and that step in that direction. I'm curious, was there ever in your training or your earlier experience where you observed something about this population and said, this could be so much better or this isn't right?
Absolutely.
Yeah, can you tell me a little
So,
bit? Because I had a similar experience that I'll share with
uh,
you later, but
so this actually started for me, an interest in this, which I didn't know whether or not I would, pursue medicine or turn this into a career or pursue psychiatry. But for me, it started in my family. So, as I think so I'm the youngest of 4 kids, and I have an older brother who is 7 years older than me. I was in middle school when he was away at college and had his first break. So, you know, as like a, I don't know, 11, 12-year-old
yeah.
like at home,
Wow.
we had to bring him back from school to be at home with us. I think we tried, he got hospitalized a number of times. We tried to do what we could to keep him in school where he wanted to be. He was brilliant, really, really intelligent, really phenomenal mathematician, studying physics and math. And we brought him home, and just seeing him go through this cycle of hospitalizations over and over and over again, seeing his struggle with medications and not wanting to take medications, not liking the side effects of medications, feeling like, this changes how I think, or this changes, you know, who I am in a way that I'm not comfortable with. And just seeing that battle, it was very frequent that, we would find piles of pills in his bedroom and he wasn't taking the medication, and then he would be back in the hospital, or, getting him to follow up consistently with a psychiatrist was really hard. So most of the care that I witnessed him getting was through hospitalizations. And a lot of times it was very brief and it wasn't enough. And it was very, very difficult for our family to get him the help that we knew he needed. And so that was sort of my early experience of psychiatry. And I think going into that, I had no idea what psychiatry was. I had no idea what different types of mental illness were. My family didn't either, right? Like we had no idea what was going on. And I think looking back, we're like, oh, there are probably things we could pinpoint that might have been signs of this, but we were like most families that had 0 experience with it, 0 knowledge about, the healthcare, mental health care system, and how to get people help. Um,
So for you, it's personal. Like
yeah,
to go back to my
absolutely.
question,
Huge.
I was not expecting that answer that you started thinking about this from your family
Yeah,
experience at age 12, 13, and
yeah.
that's a hard enough time for a kid to have a family member going through something like that. How does that experience inform how you work with families of your patients now? I imagine there's some, you know, it's a peer experience in a way. You've been there, you've lived through
Mhm.
what it's like to have a family member experience this. How does that kind of shape the way that you care for patients and their families?
I mean, I think it absolutely informs, who I am as a physician, as a psychiatrist. Probably the most significant way, and I think I realized this, very early on in my first psychiatry rotation when I was in medical school, was I think 2 things. One is I'm very comfortable with people experiencing psychosis. So for me, that was never really a frightening experience, maybe because I had already dealt with that part. But sitting with somebody in a hospital who was actively hallucinating, responding to internal stimuli, talking to themselves, who were paranoid about things happening, experiencing delusional thoughts. For me, you know, I just already had a lot of experience sitting with that and knowing, you know, being able to see a person who's behind that, where they may have come from, who they might be outside of those symptoms. So I think it sort of was an automatic comfort level and an automatic ability to see a little beyond those surface level symptoms. So I think that was one benefit, one way it sort of informed how I practice. And I think the other one is seeing people experiencing this level of symptoms that often I think can seem frightening or very other. Seeing them as part of a system. So for me, automatically, it wasn't this person in front of me. It was okay. All the other all the other people and systems impacted by this person's illness because you know as a family member. I've already experienced all of that. So it was okay. Who does the person have around them? What has happened to their support system? How have they either stayed connected or become disconnected from their community and
You don't
help
go
me
right
kind
to
of
the illness, you go to
right.
the person. What is the whole person care,
Yeah.
right? I mean, I'm sure that patients and families, whether or not you share your story with them, I'm sure they feel that when they're sitting with you, that you're not just looking at this as this is a disease or an illness that I need to treat. Here's a person who has likes and interests and
Mhm.
things that they want to do with their life, and how do we navigate these symptoms in the context of that.
Yeah, absolutely.
So you mentioned that in your family situation that maybe there were some signs earlier on of a trajectory that if you could go back in time you would have maybe said, oh well, that maybe that was a sign or a symptom. In terms of what you've learned, because you are now an expert in studying and treating psychosis, do you think that there is a better way for the mental health system in general to have any sort of early intervention or recognition of what we call prodromal symptoms, right? Like
Mhm.
things that could be indicative of disease progression later on. Is there anything we could do different? In certain areas of behavioral health, there's a big emphasis on
Mhm.
early intervention. If we can get to this sooner, the outcomes might be better for people. Do you think that's true when it comes to psychotic disorders?
Absolutely. Um there's still it, it's complicated because there's still so much that we don't know. I think this is really a growing area of research and of interest, and there's so much that we're sort of doing and learning about it. Um, there's a lot of research that's being done trying to identify, not just using the idea of prodromal symptoms, um, but trying to identify sort of like biomarkers early. There's research groups that are working on um, using technology and sort of app-based screening tools to pick up on some of these early symptoms. Some of the changes in thinking patterns, some of the changes in social interaction, motivation. So there's a lot of those things being developed. I don't think we have. It's not really there yet. I don't think we have the tools yet to do that. And I think uh, we have a lot of programs that are being built that are targeting first episode psychosis. That's not quite the early intervention, prodromal early, the as early as we want to be able to catch it, but it's still something, something um, like at Yale, the STEP program for first episode psychosis, the On Track programs in New York. Most states are coming up with how do we target first episode psychosis, catch it really early because we know treating it early gives us, the best chance of getting people better um, and avoiding some of the, treatment resistance and cognitive decline and the things that happen later on.
Speaking of the cognitive decline piece, is this something that you can see? So let's take schizophrenia, for example. Is this something that you can see on a brain imaging scan at any point in the progression of the illness, as it tends to start at a certain point in life and then potentially, depending on what interventions are in place, it can get worse with time or better? Is there any brain imaging that shows evidence of this?
Definitely, yes. How often we get brain imaging that is specifically looking at that and how accessible that is, that's a different question. But in research studies, when we can do really advanced, brain imaging with MRIs, um, there are things that we can look at that show a change. Um, you see some like atrophy and some dysfunction in different areas. Um, I think fMRIs, where we can actually look at how different areas of the brain are sort of connected and functioning, can show that better. Um, but that's not used in routine clinical practice. It's not, we're not screening people regularly throughout their illness. Those are more for research
Right,
protocols,
right.
and it's so expensive to
It's
use
so
those
expensive and access right,
tools.
right. And really how much does it tell you? And are there better interventions where you can actually see more progress and because the way the illness expresses itself is through symptoms that are positive or negative, right? So positive symptoms being things that you can really kind of observe and see and are things like auditory hallucinations are
Mhm.
positive symptoms,
Could be
right?
hallucinations, delusions, disorganized speech, disorganized behavior, and then negative symptoms tend to be that, like, lack of motivation, apathy, sometimes poverty of thought, social withdrawal.
Right. In the work that you've done, is there anything that you think, I guess, in the last 5, 10 years is especially exciting or promising in the treatment of psychotic disorders? Anything that you look at as like, wow, this could really be something? We might make a big impact.
Yeah. I think there's a lot of things that are changing and will continue to change in terms of what we know about psychosis in general. Things that I'm excited about, I mean, in terms of treatments and medication, the way that we are understanding psychosis, how those symptoms happen, how they develop in the brain, I think is shifting. We went from some in terms of the biological sort of neurological basis, we went from, knowing a bit about the dopamine system and how that plays into these symptoms that people are having to now understanding that it's much, much more complex than that. There's the glutamate system involved, NMDA receptors, there's even precursors to that. And even more so, it's about the connectivity between these systems rather than about a specific neurotransmitter. And so, in light of that, there's a lot of different treatments coming down the pipeline, which I think are pretty cool. There's a medication that's being researched right now called evenamide. That's one thing that I'm kind of interested in. Um, Specifically, it's targeting sodium channels, but has sort of downstream effects to the glutamate system. There's some ideas that what that medication is going to do is going to decrease um, excessive glutamate activity in certain areas of the brain that we think are responsible for psychosis. It's going to be able to sort of down regulate that and calm it down. There's some ideas that that's going to help better with cognition, with some of those negative symptoms, which we're not really getting with some of our dopamine agents, which are most of our antipsychotics right now. Um, so I think, coming up with new novel treatments that work differently, that may work with what we already have or may work, in a different mechanism and be able to be effective independently of the medications we have. I think that's really interesting.
Do you think the side effect profile will be a little more easily tolerated in terms of, I mean, I when I think of
Yeah.
these medications that we have that exist for schizophrenia and other psychotic disorders, I think one of the problems with adhering to medication and um, the downside of some of the physical side effects has been a real challenge for people.
Yeah, it's huge.
Um, and I remember, so in my experience in my first job right out of college, I worked at a day rehab for adults with severe mental illness. Most of them, I would say, with psychotic disorders. And I, as a young person, the first thing I noticed was it's such a shame that these medications create some of these metabolic conditions,
Hmm.
and it's like this trade off between your mental health and your physical health. Do you think we've made good progress in that area, or is that still very much a concern?
Still a huge concern. And, you know, I don't think we have a great, I don't think we have great um ideas or sort of an understanding of what to do differently to kind of be able to filter out some of that effect of the medication specifically. We have better and better ways to manage the metabolic side effects. Starting people immediately that are on atypical antipsychotics, on something like metformin, talking about starting a GLP-1 medication if they need that. We can mitigate some of the weight gain, some of the insulin resistance. So we have more tools to do that. I don't, I think sort of the nature of some of the medications and how broadly they're affecting the not just the brain but the entire body. I don't know how we're going to be able to tailor that in the future to make them more precise where they're not having um these really like broad physiologic
Mhm.
effects on your
Right.
whole body. I mean, antipsychotics specifically, um, there's like 5 different ways that they impact your weight and probably more than five, and your insulin resistance. And so there's all these different pathways that they're doing that through. So being able to kind of prevent that seems like a tall order that
Yeah.
is not there yet. We're still understanding all of those downstream effects. I think that's actually should be the goal, and hopefully at some point we'll get
We
there.
can be precise, and
Yeah.
it's interesting because I know a lot of the medications, at least some of the earlier antipsychotic medications, were kind of discovered by accident, right? Like, they
Mhm.
were prescribed for something else, and then people realized, "Oh, wow, when this person
Mhm.
takes this medication, it seems like their psychiatric symptoms
Mhm.
improve."
Mhm.
And I wonder at what point we'll completely escape from that,
Right.
that
Right.
side of medicine where I think it happens in, like, every disease.
I
We
think
we
that's the
discover things all the
beginning.
time,
Yeah.
right? But how can we then take what we learn from that and really target the therapy to not have
Yeah.
those broad side effects?
I I I mean, in a way, I think that's the phase that psychiatry is finally in now. We built all of the medicines that we have for psychosis around like that first initial discovery of thorazine, chlorpromazine, and how that affected and how it happened to help people experiencing psychosis. And so all of our antipsychotics, act on dopamine and are related to that. Um, and we haven't really come that far away from it yet. And but a lot of the medicines that now all of a sudden are starting to be researched, involving different mechanisms are really coming from and driven from the research on, okay, what else do we know besides this dopamine pathway? What else do we know about how these symptoms develop, and what other potential targets could we have? So I think we're finally getting some like um, novel drug development that could potentially do something really different. And Cobenfy is like a, a medicine that lots of people are interested in that has already come out that acts a little differently. So that's an example of it.
It's exciting, and I think it gives people hope, right? That this is not something that the evolution of these treatments is not stagnant. People are thinking about what's next, what can we do differently, how can we develop. And so I think for people listening that have a family member or friend or loved one that's going through something like this, I always like to keep in mind that medicine's changing and it's changing faster now than ever. I think with AI
Absolutely.
and research, and
Yeah.
there's so much opportunity for hope,
Hmm.
and that, being diagnosed with a psychotic disorder doesn't necessarily mean this is, the end of my life, right?
Absolutely
That
not.
there's
Yeah.
options. So I'm going to shift gears a little bit from the more kind of medical treatment side of things to kind of the experience of a person who has psychotic symptoms. You've obviously treated many, you've
Mhm.
known people, you've had personal experiences. What is your insight, without necessarily experiencing it yourself? What does it feel like for someone to experience these symptoms? How can we help the general public kind of understand what it's like to walk in those shoes?
I I think that's is a very sort of wide-ranging, um, experience, because psychosis can look like so many different things. Um, so I think there's a series of different things that it can look like and feel like, and our go-to that we associate psychosis with is probably auditory hallucinations, right? Hearing voices. Um, that's, only a subset of what psychosis is. I think there's a lot of information out there about what that experience is, what that feels like. It can be very disorienting. Um, and people experience that in many, many different ways. So for some people, it's like I hear mumbling or whispers that are distracting that come and go. Um, and it gets in the way of me functioning. For some people, they're hearing voices that are commenting on their lives, often saying things that are very negative, derogatory. And, for a while they try to fight back, and then it just gets harder and harder, and it starts to become it starts to influence sort of how you see yourself and how you view the world, when that's something you're constantly hearing. Sometimes there's lots of voices, sometimes it's very threatening. And then for other people, sometimes there are positive voices mixed in there. I've had patients who have some voices that they hear that are really comforting and really can be positive. And so the, you know, that part they hold on to and they don't, and that's something that's actually hard for them to let go of, and maybe a reason that there's sort of some resistance to treatment. Um, Not wanting to let go of that part if that's a positive experience. Um, so that's the auditor hallucination piece, which can be common, but a little more common in something like schizophrenia. Um, in other areas of psychosis, whether it's schizophrenia, schizoaffective disorder, bipolar disorder, or even substance induced psychosis, there's a lot of paranoia that people experience, a lot of delusional thinking people experience. I think that's a little harder to kind of get a grasp on and to understand that experience.
And I'm correct in saying, right, that experience is very real for that. Like if someone's having a delusional thought or is paranoid about something, someone else saying to you, "Oh, don't worry about that. That's not true." From what I understand, it's really a kind of a tightly held conviction that this, no, I believe
Absolutely.
this, right? Like you
Not only
can't
do they believe it, it's actually happening to
happening to
them.
them. Yeah. Yeah.
It is like that is their
Reality.
reality, that
Yeah.
is their experience, which there's no way that you're gonna convince them through telling them differently, right? Same with hearing voices. Like, there's no way you're gonna say, "That's not actually
That's
happening,"
not
because
real. Right. I hear it.
in their
Yeah.
brain, it is happening,
Right.
right? And you can
Right.
actually see that when they do imaging, you get, like, areas of the auditory cortex of your brain is lighting up, like they are hearing something. Um It's just created sort of internally, it's created by your brain, but it's still there.
Well, and I think sometimes when people think about other people hearing voices, they imagine it more as like an internal experience, like when
Mhm,
we all think to ourselves, right? So we
mhm.
all have these internal voices that we have, but really for someone experiencing psychosis, it is as real sounding, right,
Yes,
as me talking to you right now or you
yes.
hearing this podcast right now, like that is the experience for that person.
Absolutely. Yeah,
And actually the brain imaging is interesting that that actually
yeah.
validates that,
Mhm,
like, it is the same as hearing it.
mhm,
And imagine how hard that is to live life every day and try to focus or
mhm,
ask questions or be engaged in treatment. So
mhm.
I imagine when you're treating people, you're looking for, are some of those symptoms starting to settle down so the person can more meaningfully engage.
Absolutely. Yeah. Yeah. Is it getting more manageable? Is it getting quieter? Is it happening less often? The other major factor is how much control the person feels like they have over it. That's a big thing that I find, that I often talk to my patients about is how much of this feels like you have some control over it or not. And if we can shift that locus of control back to the person, if they can start to feel like they have some control, that they have some ability to, um, some ability to quiet it down, some ability um, to ignore or to reality test or to think about those symptoms differently to help them cope with it better, to help them be able to function, to live their lives. I think that's a really
Do you start
important
to
piece of
see
it.
yeah, do you start to see people coming from that place of like, "This is real, this is happening to me now," to being able to say, "Okay, I'm still hearing these things, but I'm starting to"
Yeah, I think I know what you're
you
saying.
know what
So
I'm saying, right?
there's
Like
different. So I'll give you a couple examples. So yes, but there, it's wide ranging. How much insight and awareness develops, but that
yeah,
can happen with any of these symptoms, with auditory hallucinations, with paranoia, with delusions. Um, so, you know, there are some people who have schizophrenia. There's a subset of people with really poor insight that seems to be almost part of the illness, right? And that's anosognosia, this idea of being unable to know, what's going on within yourself. Um, that specific subset, it's really challenging and we might not get there. I might not, they might not be able to say, I'm, the voices going on may not actually be God, right? They may
right,
not actually be, um, they may not actually be something, in this world. They might be something that is part of an illness. And you can get people sometimes to say that. Um,
right, or letting go a little bit of a delusion. Like,
mhm,
you see people say, I'm
mhm,
starting to think that maybe that isn't true,"
mhm.
or yeah,
But there are people who already start off at that point too. Like I see a lot of people, particularly in earlier psychosis, like first episode, the first couple episodes people go through where you can have a really variable level of insight. So you can have people who show up who say, this is what I'm experiencing. It's really disorienting. Like I'm hearing these things when um, there might be specific triggers. Like when I look at this person, I hear their voice saying this. I don't think they're actually saying it. I'm not sure though. They might be, but I just can't stop thinking that they're the ones saying this. So, you know, people can have this sort of like in between variable level of insight where it's like, this seems like a weird experience. I'm not sure about it. Um, but it's also happening to me.
right.
Um,
But
and
there
so
is
you'll
that,
see
like,
them
little
grapple with it.
there's a grappling, which
Yeah.
is that's what I'm, like, trying to get at, is there is some wiggle room there
Hmm.
as someone is either getting
Hmm.
better or that's kind of where they start.
Absolutely. Absolutely. I see the same thing with delusions. I mean, you know, sometimes they won't fully get better. It's like, if somebody is firmly believing like delusion is a fixed false belief, right? I believe this thing to be happening, that there's no evidence supporting it's actually happening, right? But I still believe that this is happening. Um, a lot of times, you'll see delusions are harder to treat than any other psychotic symptom. And a lot of times the progression of that is sort of a softening. And it's like, okay, you'll introduce a tiny bit of flexibility, after being on medication, maybe working in therapy too. Being able to recognize, okay, maybe it's not quite happening the way I thought it was happening. It's maybe there's a possible another explanation. I still think this is what's happening, but there might be another explanation for it. Um, And even if they don't completely let go of that, a lot of times by the time people get better when they're experiencing delusions, they can look back and say, this thing was happening, but now for some reason it's not happening anymore. And they kind of create, a narrative to explain that. And that's okay
That is yeah,
as long as it's not
as
happening
long as
now.
it's not happening, right? Yeah.
And then you can work on making sense of the fact that it
Was.
seemed like it was happening or it was
Right.
happening for you before.
Have you had any moments with a patient that changed how you think about psychosis? Any experiences in your I mean, you've worked with, I imagine, hundreds, if
Yeah,
not thousands of patients at this
many,
point.
many, many.
Any that stand out as um, learning experiences for you where you had an aha moment, kind of change the way you think about things?
I don't think there's like one case that stands out as an aha. Um I think there were I mean there's probably small things that I learn from every single patient that I work with and treat. There's one patient who I don't know, when I think about experiences I've had, or challenges I've had sort of building a relationship and connecting with people, there's one person that sticks out in my mind, from a bit earlier. I think it was probably one of the very early years of being an attending psychiatrist on an inpatient unit. Um, and there was a woman who had been in and out of a number of different hospitals, had not ever taken medication. Um, she hadn't wanted to. She was very against medication, um, and wasn't severe enough. Like she didn't sort of get to the point where anybody could make her take
Mhm.
medication.
Mhm.
Um, and so I kind of had my work cut out for me. She was having very extensive paranoid persecutory delusion. She was having hallucinations, but very interestingly, they also involved not just voices, but tactile hallucinations. So she was having this sort of complex system of experiencing people who were voices, but also she felt something that would come and sort of stitch um stitch things into her body,
Wow.
which was like a very I had never, I had never worked with somebody who had experienced something
Right.
like that before. And so
And I take it she
it
was
was very
distressed
powerful, very
distressed by it?
distressed,
Yeah.
very distressed. She was very paranoid about it. There was a whole, system about why this happened and what was going on. And it was uh, so visceral for her, because she was experiencing this physically as well, and so terrifying, and didn't get treated. She was in and out of hospitals, and so I I have a really sort of vivid memory of me being an early inpatient psychiatrist, like, "Okay, I'm going to get through to her.
Determined.
I'm going
Determined.
to figure out how to help her." And it took a long time, and a lot of what I worked on with her was really just being very open, understanding her experience. There was a lot of time I remember spending, 45-minute sessions with her, sitting and t and letting her explain to me, like, "Tell me your experience of this. Tell me how you know this is happening. Tell me, um, why you think this is happening. Tell me the meaning behind what's going on." Um, and and I think just being open and showing her that I am sort of here with you in this experience, um, I think went a long way to starting to gain her trust. And then the conversation became, she knew that I, wanted to convince her to take medications. And then the conversation became, you know, what if, what if there was something that could shift the way that you experience this? What if there was some way that this was less distressing for you, or that it was less painful, um, or that maybe it didn't happen as often? Um, and it was she wasn't very open to that initially, and then over time it was do you think that's possible? Do you think there's a chance of that? And I mean, my number one sort of rule is that I'm always honest. I'm try to be as genuine as possible. I try to be as honest as possible with patients. I said, like, absolutely, this is what I think could help, and worst case scenario, it doesn't, and then you don't take it, you know? You try it for one night. If it doesn't cause a problem, if it helps a little bit, who knows? Um, and I think, just building enough trust. I'm not sure she was convinced that anything was gonna help. I'm not sure she wasn't convinced that medication was gonna do anything, but she trusted me and she, you know, I guess believed enough in me and what I thought might be helpful that she was willing. She tried it for one night, no real problems from it. She tried it for another night, no real problems from it. So she was okay with sticking with it. So it was one day at a time. After a couple days, I remember her saying, Dr. Gardner, it's not, you know, I don't know what's changed, but there's something different. There's, I don't know if it's happening in the way it was happening before. Um, it's bothering me less now, or it's happening less now. And over time, like it took a couple weeks, but after a couple weeks, there was a moment when she was able to sit with me and she was able to say, like, do you really think that my brain might have created that? And that was kind of wild to me
That
because
is
she was also the
amazing.
person, she was one of the first, people I worked with that really developed like a real level of insight. And so that was impressive. That was a different experience for me to work with, but she was able to say that. And I said, I don't know, but yeah, I think it's possible. And maybe if taking medication made this experience different or change or go away, maybe maybe that means that it was.
Right.
And she was kind of able to hold on to that, which some people are and some people aren't. So, that stood out to me. And I think what stood out was, okay, eh, really needing to understand each person's unique experience of these symptoms, needing to really spend the time to develop that relationship, to build trust, to find to find that connection of like what's important to you, what is it that I can possibly help you with, what is it that medication could possibly help you with, or therapy, and how do we work together to get there.
I mean, in hearing that story, that's exactly what I take away from it too, is she needed to trust. You took the time to develop the relationship where she could ask the question and feel comfortable and trust that you may know something that she doesn't, and that you're a safe person that she could take that step when obviously no one else had been able to get to that point. And I think that kind of takes us back to one of the problems with inpatient care and the speed at which we
Mm,
have to treat people because of the restraints that we're under with payers and other issues is when you when you take the time to develop the relationship, people can trust and take a leap of faith, basically. And I think that's true with a lot of conditions. And I think
mhm,
it's just part of what makes us human is our relationships with each other. And it's a beautiful story of how so much of being a doctor in our field is not really just your expertise and what you know about medications. It's just about being a human
mhm,
and sitting with someone and really trying to genuinely understand where they're coming from.
mhm.
And if that is the work that you continue to do here, I can't tell you how lucky we are to have you on our team. All right, I'm gonna throw one closing question at you.
Okay.
If I came to you and handed you $50 billion to do anything within your field of passion and study, which is treating psychotic disorders, what would you do with the funding and why?
I don't even know what I would do with that
It's a
money.
lot of money.
I mean, I would be tempted just to like feed the world.
Yeah, I know, right, right. There's
Um,
bigger problems out there. Yeah.
I don't know if there's a super specific sort of research area. I think it's just putting as much funding as possible toward understanding really the neurobiologic basis of psychosis, um, what's what's really happening within the brain in terms of sort of genetics, and then the environmental influence that then might, activate certain vulnerabilities or predispositions. I think we have to understand that more. We have to get a lot more research, a lot more funding into those areas, because we can't do the prevention, we can't do the early intervention unless we understand that better. We can't do precision treatment, and develop the medications unless we understand that better. So I think it's putting all of that funding toward really understanding what these illnesses are. We have, this is a whole separate conversation, but we have, you know, this DSM that has explained different diagnoses based on syndromes, based on clinical symptoms that we've put into these different syndromes that actually probably aren't necessarily separate things, especially when it comes to psychosis, schizophrenia, schizoaffective disorder, bipolar with psychosis. Even now, what we're seeing with these long term psychotic disorders that are developing related to high potency cannabis use, or other substance use, um, they're probably not distinct things. There's probably many, many, many things that
We're always
are
trying to
overlapping.
categorize, like, it's so,
Yeah,
I think, uncomfortable for people to just not have a label, right? Like,
yeah,
it helps us think of things in a construct, and it's not always
yeah.
it doesn't always make sense, even though it's how we make sense of things.
Hmm. So probably, I mean, probably in terms of psychosis specifically, um, those diagnostic categories are not going to hold up long term.
Mhm.
That's going to be shifting.
It's more of a spectrum, would you say?
Um, so not even necessarily. So, they just came out. There's a article that was sort of summarizing where the DSM is going in the next edition, with this current work group that's working on it. And they were looking at this, and one of the areas of research are these biotypes. And this is something, we never heard much about because this is like newer research. So when I was training, nobody talked about this. But now they're looking at, measuring these different um, neurological measures. They're using EEGs, MRIs, um, oculomotor movements, and they're measuring all these groups. So when they split up, and this may or may not be, the future direction, but it's one thing that we're looking at right now. They're splitting up. They can split up people that have psychosis into these three main different biotypes. And what they're finding is that may, we don't know enough about this, they're doing research about it right now, but it may influence what kind of treatments people are more responsive to. And what they see is that each of those biotypes have people in them that have a schizophrenia diagnosis, or that meet a bipolar diagnosis, or that meet schizoaffective diagnosis. So we have those three diagnoses, but you can find those diagnoses across all three of these biotypes, but that, like, maybe early research is showing that these specific biotypes might separate this way in which people develop or experience psychosis differently, and they might be responsive to different types of treatments. Like, one group is looking like maybe it's going to be more responsive to clozapine. Um, and so that's really interesting. And
Fascinating.
so
I hadn't heard about
they're kind
this.
of working that into the DSM in terms of psychotic disorders.
I wonder if the biotypes thing will translate to other conditions and, like, are we all
Maybe.
just one, all of us can be categorized into one biotype. What does that mean for other
Yeah. I
diseases and Yeah.
I don't know
Interesting.
enough. I think for psychosis, it makes sense because there's something different about people that develop psychosis. There's something that makes, you can see it in bipolar disorder. There are people who experience bipolar disorder that just have mood symptoms and that won't develop psychosis.
Mhm.
And then it's something like um, basically 50% ish of people who have bipolar disorder will at some point experience some psychotic symptom. So that's half of the people. If you cut it back to people who actually have full manic episodes, it's something like 60% of people in a full manic episode will experience
Mhm.
psychosis. But there's something very different about someone who has bipolar disorder that doesn't experience psychosis versus someone who has bipolar disorder that
That
does.
does.
There's something different about their brain, about the way things work that push them over that edge to the blurring of reality, to not being able to kind of filter out um all this other sort of background information happening in your brain that then gets interpreted as
It's
psychosis.
it's fascinating. So, to summarize and recap, if you were given all of the money, you would I mean, this seems like this kind of
Get
research and
answers.
yeah,
Yeah,
getting answers like that you can't do anything else until you know what you're working with and we're demystifying and understanding and then
yeah,
you can make decisions from
yeah.
there. Is it, create 10,000 more silver hills because we're going to need more places for people
Definitely.
to, right?
Definitely.
um
Also, I would say we'll have to put some of that money. We want to get all the answers as to what's actually going on, what's happening. How do we really conceptualize and understand, the neurological, biological basis of what's going on. But then also I would say like a significant amount toward um education. And I think education of families, I think it should start with like pediatricians.
yep.
Probably pediatricians should all have access to a psychiatrist who's helping them to give psychoeducation to their families, um to patients,
We have such a
and
long way to
decreasing
go. Yeah.
stigma, right?
Yeah.
It's like
Yeah.
those
I
are
mean, the average
the
person
other
just
major
knows, the
areas.
average person just really knows nothing about any of this. And that's a huge area for improvement, just culturally and in society. And I think some cultures do it better than others, but generally just people having a basic understanding of these things
Yes.
can change a lot.
Absolutely, in terms of catching things early and being able to intervene.
Dr. Gardner, I won't keep you any longer. Thank you for being here with us today.
Welcome.
This has been, for me, a fascinating conversation. And hopefully, for those of you listening, you have learned just as much as I have. And like I said, in listening to you talk and the empathy and the place that you come from in how you take care of people is admirable. And we're so lucky to have you. Thank you.
Thank you.
You've been listening to Conscious Mind on Silver Hill Radio.